Good morning. All right, we have everyone who is going to be here today, so we will get started. I'll call this meeting of the El Paso County Public Health Department Board of Health to order at 8:31, and we will start with the roll. Vice President Salt?
Here.
Commissioner Geithner?
Here.
Commissioner Nelson?
Here.
Mayor Dixon is excused. Councilman Donaldson is excused. Dr. Chan?
Here.
Dr. Collins?
Here.
And I'm here as well. We have a bit of an echo. Okay. Approval of the agenda? Need a motion and a second.
I move approval of the agenda. Second.
All those in favor?
Aye.
All opposed? Motion passes. Agenda has been approved. Board of Health comments. We can go around the room and I'll go next. Oh, man. Let's give it a minute. Is it the Teams meeting? Okay. Oh, well, that's muted. Oh, it was the meeting is still going. Okay. Okay. So we'll get started. So I will go first, and I want to use this time to honor Miss Doris Ralston's service. Miss Ralston has resigned from the board. I believe her seat was up soon anyway. She wanted to spend some really well-earned grandmother time with her newly born granddaughter. So congratulations to her and her family. We have our certificate for her, and we'll make sure that she gets it. But I did want to read some comments and would encourage and welcome any other comments from the board. So Doris submitted her resignation from the Board of Health on June 23rd, following nearly 9 years of distinguished service. She was first appointed on July 31st of 2017 and generously agreed to serve a second term beginning August 1st of 2022. Doris also served as Vice President of the Board from March 24th, 2021 through December 10th of last year. In this leadership role, she was a steady, thoughtful, and trusted presence on the board. Her commitment to public health and to the residents of our community helped guide the organization through periods of significant challenge, change, and accomplishment. The board and staff are deeply grateful for the time, expertise, and perspective she shared. Throughout her tenure, Doris asked insightful questions, offered sound counsel, and demonstrated unwavering dedication, qualities that made her service especially meaningful. Her contributions have had a lasting impact on shaping El Paso County public health into the organization it is today. With her recent retirement as Executive Director of the Colorado Springs Osteopathic Foundation, we know she's looking forward to spending more time with her family, especially her beloved new granddaughter. While her presence will be greatly missed, we wish her the very best in this next chapter. So, thank you, Doris, and would welcome any comments as we go around the board. Commissioner Nelson, why don't we start on this side first?
Just thank you, Doris, for your time, and I enjoyed getting to know you the brief amount of time that we both served together on this board, and I'm grateful for your willingness to serve all these years. Thank you.
I'd like to recognize and thank Doris for her work and her dedication, and I always appreciated her quiet and thoughtful leadership, and I also appreciate the way that she always approached all of her topics with pragmatism, and she will be sorely missed, but I hope she really enjoys her new grandchild and her time off.
And
On behalf of the team and staff here at Public Health, I would just like to express our gratitude to Doris for her time in service. She joined us in 2017, so she's certainly been with us through a lot of changes within the department and within Public Health, and thank her for her leadership during that time. And I'm always grateful for having volunteers in the community that are willing to dedicate nearly a decade in service to public health in our community through volunteering to be on this board. So very thankful for her presence and her leadership over those years.
Yeah, I agree with all that's been said, we're grateful for, citizens especially who step forward to serve in our volunteer roles. So grateful for that service, and I am really excited for her that she is going to get to enjoy so much time with her granddaughter. I can't think of a better reward in retirement and to be able to do that.
Having only just met her, I appreciate her service and would like to continue that legacy.
Great. Thank you. Any other comments from the board? Okay. We will continue our agenda to the approval of the minutes. I do need a motion and a second.
I'll move approval of the minutes.
Okay. Commissioner Nelson?
I'll second.
Commissioner Geithner seconds. All those in favor of approving the minutes, say aye.
Aye.
All opposed? Motion passes. The minutes have been approved. Do we have any public comment on items not scheduled on the agenda? I don't think we have anyone online. Is there anyone in the room? Okay. Seeing none, we will continue on with item 6, Finance and Budget Report. So we'll start with our 2025 Annual Comprehensive Financial Report and Audit Presentation.
Good morning, Board of Health members. I don't know is this on? Okay. Good morning, Board of Health members. Nikki Simmons, El Paso County Chief Financial Officer. Here this morning to present to you the results of our annual audit. And I have handed out copies of our annual comprehensive financial report. I'm joined by Ted Williamson, who's a partner out of the St. Louis office of Reuben Brown, who's our independent auditor. They have spent the last many months auditing the results of our operations from 2025. And so he is here to go through some required communications with this board regarding the audit. Before I turn it over to Ted, I just wanted to give a giant shout out to our accounting team led by Debbie Perry and Jody Pinnell. They do a fantastic job keeping all of your finances in order, coordinate very well with the public health staff. Lauren Miramont and her team work incredibly hard over here to run your budget. And this is the results of the operations from every single part of your organization. So it's not just the finance side. There's a lot of things that go into this audit of your internal controls, how every department handles cash, all the transactions that flow through into this final document. And so I'm not going to steal too much of Ted's message. Sometimes I do, but we're really pleased that we have an unmodified or a clean opinion from the auditors and no adjustments that were made from the results that we present to you. So what that really means on our part is that the information that we present to you on a monthly basis or a quarterly basis, you're getting accurate information to be able to manage and govern for the organization and don't require the auditors to come in and make adjustments to that. So with any other questions for me, I will pass it on to Ted Williamson.
All right, well, thank you, Nikki, and good morning, everyone. Again, my name is Ted Williamson, partner with the firm of Reuben Brown, and just wanted to go over the results of the fiscal year 2025 audit with you. So there are really two parts to the audit. First of all, we audit your financial statements to make sure that those are correctly presented, and then we also do what's called a single audit, which is compliance audit with the requirements associated with federal grants. So I'll talk about each of those in turn. For the financial statement audit, again, the purpose is to make sure that your financial statements are fairly presented in accordance with generally accepted accounting principles. As a governmental entity, you follow the standards set forth by the Governmental Accounting Standards Board. And then when we conduct the audit, we follow the standards set forth by the American Institute of Certified Public Accountants, as well as, because of the level of federal funding that you receive, we follow what's called government auditing standards that are set forth by the Governmental Accountability Office of the federal government. It's important to note that while we render an opinion on the financial statements, as Nikki mentioned, ultimately it's the financial staff of the department and of the county that is responsible for preparing the financial report. And additionally, while we consider your internal controls and would bring to your attention any internal control concerns that we identified, the opinion that we give is not on your internal control structure, is on the accuracy of your financial report. With that background, we're pleased to tell you, as Nikki mentioned, that we did issue an unmodified or a clean opinion on the financial statements, and we did not find any adjustments during the audit that needed to be corrected. It's not uncommon on an audit of this size to at least have some adjustments that have to be made to the numbers for the financial statements. So the fact that there were none is a very good result. As far as the single audit, which I mentioned, Public Health spent $22 million in federal funds during 2025. Now, when we do the single audit, we don't look at all of that. Instead, there's a formula the federal government sets forth that has us look at either the highest risk or the largest programs. So this year we looked at the Supplemental Nutrition for Women, Infants, and Children's program, which is about $15.5 million of that $22 million. And again, we did not have any findings, did not identify any internal control or compliance issues, and issued an unmodified opinion on the single audit as well. So to sum up, I think very good news, unmodified opinion on the financial statements and on the single audit as well. Happy to answer any questions you might have on the audit or on the results.
Any questions from the board?
I don't have a question on the audit, but I do have a question about the general finances. And I think my question primarily relates to funding of pension and benefits other than pensions, post-retirement.
Mm-hmm.
Where do those funds come from, and how's our standing in terms of funding that?
Sure. Well, Nikki, I don't know if you've got anything else you want to add on that.
Yes, I can. Dr. Chan, if I understand your question correctly, you're asking about our funding of our pension and our other post-employment liabilities. And so we do obviously offer a pension to our employees. We are participating in the El Paso County Retirement Plan, which is a multi-employer plan that is governed by a separate board. That separate board sets the required contributions. And so we, as public health, have made all the required contributions to that plan. El Paso County as a whole is the primary sponsor of that plan, but it does have 5 employers in the plan. That plan, if I remember correctly, is about 65% funded, 63% funded at this point. And it is on a trajectory to be 100% funded within the next 28 years. And so that is something that is within the bounds of average for most government pensions. And so we are contributing 12% of employee pay right now to that pension. And those funds come from however the employee is funded. So if the employee is funded from a grant, those funds come from that grant. If the employee is funded by public health general funds, that comes from that general fund. The other post-employment benefits is on a pay-as-you-go basis. And so we utilize current year funding to pay those benefits for people who are currently funded. There is not a trust for that.
And so the, let me see how much it is. 12 million? The 12 million net deficit, is that the projected deficit over the next 28 years, during which time you anticipate a catch-up?
I'm sorry, can you tell me what page you're looking at?
33.
No. So on the OPEB, the other post-employment benefits, we would not anticipate a catch-up. because it's on a pay-as-you-go basis. And so under accounting standards, we're required to recognize a liability of kind of the amounts we've accrued. It's all based on actuarial estimates. We work very closely with several actuarial companies to come up with that estimate. The county has no intention to create a trust and catch that up because we're constantly paying that on an as-you-go basis. So utilizing current funding to pay any claims that are created by those retirees in the current year. So there will always be this actuarial estimate in our financials, but this isn't like true debt as it's like a bond payment or we owe anybody any money currently. This is an estimate of with a whole lot of assumptions in it based on the amount of employees in the plan and what could possibly happen over the course of their lifetime. So we use mortality tables, things like that, to come up with this number. So that number will always exist in the amount in the financials. The one that we expect to reduce over time would be the pension liability. That one we are currently paying more than the annual required contribution to try to get that to come to zero. So we are utilizing more current funds than the benefit that current employees are getting in order to try to bring that liability net value to zero.
Okay, and so for that, I recall that there was what seemed to be a large deficit last year. Is there a comparison where you are noting that the percentage that is funded has gone up from last year to this year and the year before last to this year?
It was 57% funded, and this year is 63% funded.
Okay.
So progress.
And progress is being made for multiple reasons. A lot of that was we had a great market in 2025.
Right.
And also in actuarial values, we have to smooth that market value over 5 years. So if we have a great market, we don't get the results of it in 1 year, but also if we have a bad market, we don't get the results of it in 1 year. And so you really have to you have to deep dive into those numbers because that number could fluctuate a little bit, but there is an actuarial trend to get that to 100% funding in 28 years.
Okay,
is
thank
the
you.
trajectory we're on.
Great. Any more questions for Nikki and Ted? Oh, go ahead.
Just a
Commissioner Nelson.
comment to thank staff for all your hard work. And, this is something that happens every year in audit, but the fact that there were no major findings, just want to recognize the hard work that staff are keeping track of things. And these are tax dollars that we want to make sure we're using appropriately. And it's really important to be able to have this third party come in and say, hey, your accounting is sound and your practices are sound, and that there is this transparency and accountability. So thank you to staff for all your hard work.
Thank you, Commissioner.
Okay, thank you both.
Thank you.
And continuing the finance and budget discussion, we'll have Lauren come up and talk us through the May 2026 financial report.
Good morning. I also just want to thank and acknowledge the finance team that they work really hard all year round, and especially to prepare this information. So appreciate them greatly. I just wanted to start this conversation with acknowledging we just received notice that we got our budget presentation award again for 2026. You guys should have all received a copy of that 2026 budget, and this award is a reflection of the work that went into that. Oh, thank you. And then as far as
Lauren, hold on. I just want to congratulate you. I know we had brought this up. How many years in a row is this now?
I believe this is our 6th year. I can double check that, but yes, multiple years in a row to receive this award, and very grateful for all the work that goes into this.
Great. Let's give the team a round of applause. Okay, go ahead. Thank you. Just want to recognize you
thank you.
and the team. Oh, hold on. Commissioner Geithner has something to say.
So I appreciate the recognition of the award and giving that to the team, but could you just describe for us what that award actually is for a little bit so that, anyone
Sure.
can understand?
It's for meeting a lot of criteria for transparency and conveying information about our financial status. There's a lot of criteria about how we present our fund, how we present our programs, how we present our performance measures, like how easy it is to consume. And I'll just state that this next year there's going to be a big change to the requirements for that we haven't quite dug into yet. But the goal is to promote transparent communication of our financial information. So not to bore you with too many details about what goes into that, but it's a long list of criteria that we have to meet. But I can follow up with more details if you like.
I don't need more details, just I thought it would be good for everyone to understand kind of what that is about. So thank you.
Thank you. This month, I wasn't going to go through each line item since we did a kind of deep discussion of that the last couple of meetings. There's nothing new to report with our financial operations for May. I just wanted to note that June will have higher activity as we conclude our state contract year end. We're going to have some higher invoices concluding the activity from the year of that program or those programs. So next time we'll meet, we'll have a better picture of where we're at for the year. But happy to answer any questions about May's financial summary.
Any questions from the board? Okay. Anything else, Lauren?
No,
Is that
that's
it?
it. Thank
Okay.
you.
And if I could just
Go ahead,
follow
Dan.
up, it is actually our 7th year.
Oh.
Thank you.
Took a moment to look that up. It's the
Okay.
7th year of receiving this Distinguished Budget Presentation Award, and very grateful again for the work. Thank you.
Great. Thank you. Okay. We will move on to item 7, which is for the bulk of our meeting today on contracts. So we have 2 that we need to work through individually, and then we will kind of do the rest of them as a bulk discussion and approval.
Yes.
Okay.
And before we get into the specific contracts, I wanted to take a moment and just orient us a little bit to the number of contracts that we have in front of us today. These are our state contracts, so following the state fiscal year that begins July 1 is why we have so many that we bring forward in our June meeting. And these are a mix of new contracts, annually recurring, and amendments that need the board's approval. All but one are contracts from the Colorado Department of Public Health and Environment. One is from the Department of Early Childhood with the state. Our chronic disease prevention and tobacco cessation multi-unit housing, the first 2 require action because these are new funding that was not in our original budget. So to appropriate the funds into our current fiscal year, we do have resolutions for those. The remainder of the contracts are a mix of federal and state funds. In some cases, the contract is being initiated with the state funds only, and the federal dollars will be added as we move further into the year. And we have one grouping of contracts that is specific to our emergency preparedness and response program. That's the City's Readiness Initiative, as well as public health emergency preparedness. Those contracts are fully federal funds, so we are asking for your approval today on draft content that we have reviewed with the state. We anticipate that fully available contract and final contract to come to us in July. We're asking today for your approval based on draft information for us to be able to execute that contract. And then if there are any changes to the scope or to the budget once we receive the final version, we will need to come back to the board. And after those 2 contracts, everything else on your list is a contract that has been previously approved by the board and work we have presented previously, but because of where we are in the contract cycle, it's coming forward for approval today. So just wanted to add that context.
Thank you for that. Any other questions from the board, just on process or? Okay. Summer.
All right.
Kick us off.
Thank you so much. Summer South, Clinical Services Division Director. And this morning, this first contract, am I controlling this guy? Okay. Well, there you have it. Okay, there we go. So this morning, and if anybody is following along in the packet, it's on page 11. We're looking at the Chronic Disease Prevention Grant Phase 2. And so this is our LPHA chronic disease pilot phase 2. We are ending phase 1, and the funding source for this is from the state, CDPHE. So this one's a little bit tricky. Right now we are looking at $743,141 for phase 2, so fiscal year 27. It will likely be reduced to $681,773 due to budget constraints at the state level. As of right now, the contract we have in our hands is for the larger amount. It will likely be reduced to the $681,773, but we just wanted to make sure we were clear and transparent about what we were looking at today for phase 2. This is year 1 of 3 in this contract cycle. There is no match required, and it is 100% covering the work in this program. So the purpose of this contract is to implement evidence-based strategies that help reduce chronic disease risk factors and improve access to prevention and management services in El Paso County. And that's it. Any questions?
Any questions from the board?
Wonderful.
Okay. Are you done with your slides?
And that, yeah.
Okay.
Next up. Okay, there we
So
go.
we do need board action on this one. So I will
That's right.
entertain a motion in a second.
Motion Collins. Motion to approve.
Okay. Do you have a second?
I'll second.
Okay. All those in favor of approving the new funding amount for the chronic disease prevention, say aye.
Aye.
All opposed? None opposed. The motion passes unanimously. Thank you.
Great.
Okay, we'll go to our next one. On the integrated tobacco cessation and affordable multi-unit housing. Deja, kick us off.
Good morning. So yes, this is a new contract that a grant that we applied for and were awarded. This is innovative funding, and much like the chronic disease, and you'll see in our core tobacco funding, our contract that we received is for a greater amount, but will likely be reduced because these funds all come from the same pot of money up at the state. So this funding will be with our substance use prevention program and will account for approximately 13% of that program. Substance use prevention is made up of several different grants, and so this grant just accounts for 13% of that. This is state funding, as I mentioned, in the amount of $200,000, likely to be reduced to $180,000. New contracts, so we're in year 1 of 3. There's no match required. And the purpose of this grant is for us to partner with Homeward Pikes Peak and Greshio Housing to reduce tobacco use and secondhand smoke exposure among their residents. And if you're not familiar, Homeward Pikes Peak and Greshio Housing provide affordable, stable housing for individuals and families. And they also provide a lot of good resources and case management, which is why we're partnering with them. Our program goals for this contract are to increase quit attempts and longer quit duration among residents at Homeward Pikes Peak and Greshio Housing, and to increase use of evidence-based cessation services. So we're going to be promoting the Colorado Quit Line, helping connect their residents to nicotine replacement therapy and additional support. We're looking to improve compliance with their smoke-free housing policies and reduce exposure to secondhand smoke and vapor. Our core activities are going to be to train and embed resident cessation connectors. So residents that have been through or have formerly been addicted to nicotine in some way but have quit, and so they are a peer in that way and can help residents work through that themselves. We're going to be integrating cessation support, as I mentioned, into their existing resident services and case management. Through all of this, we will be conducting assessments, providing education, offering referrals, and delivering tailored cessation support to their residents. Why this matters for El Paso County, this population is in our community, adults and families in supportable and affordable housing who are facing barriers to accessing services, multiple services, but we're just going to be focusing on the tobacco cessation. And the value to our community is that we're going to increase use of cessation services among their residents and staff who currently use tobacco and decrease secondhand smoke exposure in those apartments and living situations. Any questions for this contract?
Commissioner Nelson.
So can you speak a little bit more to, it says that there is a 1.35 FTE, and so can you just give a little bit more context around the staffing and then the cessation navigators, like they're residents living within these communities or these homes, and so are they being paid by public health to be in this position? Can you just give a little bit more?
Absolutely. So, and I apologize, this is all on page 22 in your packet, if you're wanting to follow along. So the 1.35 FTE, as I mentioned, this grant encompasses 13% of the entirety of the substance use prevention program. And so we're just saying that we're dedicating, this funding is going to support 1.35 FTE of that staff.
So we're not adding additional
We
staff?
are not adding additional staff. And is there anything else I can help clarify with that?
And then the cessation navigators that are residents in these homes.
So this is an innovative funding opportunity that we received. This is supplementary to our core tobacco funds, which is why we had to apply, and it was competitive. We're one of 2 counties in the state working on this specifically. So this is it's evidence-based to provide peer support, but what's innovative about this is embedding it in multi-unit housing, affordable housing situations. So we had worked on this prior to COVID and that project got halted, which is why we were eligible to do this again. And we were making really great progress. And so we are training peers, so people that live in those at Homeward Pikes Peak or Greshio Housing, they will be paid a stipend that's written into the grant and was a requirement of the grant. So we'll be training them, but also providing training to their staff so that there's going to be a lot of support for these peers from us, from their staff, to be able to support others in the community that are trying to quit.
Are there requirements for them to earn that stipend, like number of contacts that they make within a week or a month or something like that?
Yes, and we haven't fully developed that yet, but we'll be working with Homeward Pikes Peak and Greshio Housing to determine that, and through our assessments and we still have to figure out our baseline, and so then based on that, we'll determine these benchmarks that they'll have to meet in order to earn their stipend. They're going to have to, attend certain trainings and things like that, which will also contribute to them earning their stipend.
The 1.35 FTE that will now be funded through this, was that previously funded through our general fund, and so that's freeing up some of those dollars, or is it replacing another grant that we no longer are receiving?
So we are no longer going to be receiving our Communities That Care grant. That will end June 30th. And so with this funding, and we also received an increase in our core tobacco funds, we were able to transition those staff that same positions, policy and prevention specialists, to be supported by these funds. So no additional staff, but we are moving staff that were previously funded through Communities That Care.
I think that's all the questions I have for now.
We'll go to Dr. Chan and then Commissioner Geithner.
What is the population that is housed through these 2 entities, and what proportion of them use tobacco products? Well, I would say, what proportion over the age of 15 use tobacco products?
I do not have that information readily available right now, but we can get back to you on that. Let me just see if it's in here. And Jennifer, do you happen to, you know? So we have our resident expert here. She can.
Hi, I'm Jennifer Lang. I'm the division manager for the Substance Use Prevention Program. I don't have the specific answers for how many residents use tobacco. That's actually one of the first questions that we spoke about when we met with Greshio Housing as well as Homeward Pikes Peak is, do you have a sense of the tobacco use and vape use among your residents? And just to give a perspective, statewide, it's probably about 10%. Low income is higher than that. I have to look into that. However, both agencies well estimated that to be at least 50% among that population. However, that will likely be one of our first activities that we do, is to get a good assessment and understanding of the usage and the situations and just kind of what they're looking at to establish that baseline. So that will be one of the first things that we look at is surveying those residents. However, according to the TABS data from 2022, 1 in 3 residents of multi-unit housing, especially low income, experience secondhand smoke exposure on a nearly daily basis. So it's a much significant issue among these populations than perhaps the average population of residents.
And so what is the population in these two housing entities?
They are very diverse, actually.
No, I mean, what is the number of individuals who are in these two housing units?
We are still working on defining that. With Homeward Pikes Peak especially, well, and Greshio, they both have multiple locations, and because this is a pilot program, we are starting with specific locations within each of their organizations. We're not going to be tackling this like all throughout. Sorry. We're not going to be tackling this across all of the HPP or Greshio locations. We're going to be honing in on perhaps what is perceived at the moment to be the highest impacted populations, and seeing where we can make inroads. As Daisha mentioned, this is innovative funding, so we're really working to learn essentially and inform best practices that can then be implemented throughout the state.
Okay, so this is really more of a pilot program for this year, where you're going to do an assessment of what the number of individuals who might be impacted, and the proportion of individuals who are using tobacco products within these housing units, because it's kind of hard to measure a result if you don't have a starting point, right?
Yes, this is one of the first of 3 years. So we anticipate having the funding for the next 3 fiscal years. The first phase will be that, gathering our data, establishing a baseline, and then year 2 will likely move into more, of the
More
implementation.
Okay.
So it's going to be a process over the next 3 years to get where we want to be. As Daisha mentioned, we had some funding similar to this beginning in, I believe it was 2018. We were not able to complete the 3rd year of that program due to COVID. However, the state recognized the work that we were doing, and we're anecdotally very pleased to see that we have reapplied for the program, because we were getting to the point of being able to demonstrate the effectiveness of having peer-to-peer support around tobacco cessation. It's thought to be much more effective peer-to-peer than utilizing the Colorado Quit Line or other resources.
Okay, I'm just having trouble understanding how you are able to determine that there is effectiveness with peer-to-peer support if you're unable to determine the proportion of smokers at the beginning of the program versus after the intervention is implemented? Or was that a totally different program?
Yes, so this strategy is based on other programs and taking that experience, and CDPHE has allocated funds to implement that in other jurisdictions. So locally, much like the chronic disease, we will have an initial phase of planning and preparing, then move to implementation, where the impact in these specific multi-unit housing in our community will have more data to support this particular effort locally. But it is based on similar models of implementation with peer support in other communities and evidence-based strategies from tobacco prevention. But we are at the beginning stages locally.
Okay, and so in choosing these multi-unit housing entities, there was no assessment initially to indicate that there was a need specifically in these housing units, but you simply extrapolated data from other known studies showing that low-income multi-unit housing units had high levels of tobacco use and secondhand smoke. Is that correct?
We have had some relationships with both of these organizations over the past several years. We met with them last fall while we were planning to, getting together our application for the state, and it was really based on agency readiness. The widely believed perception of high tobacco use rates among these groups locally, and then also based on the data available. These are very populations that are impacted at a much heavier rate by tobacco use than the average population.
So when they intake a resident, I mean, this perception, is it because when they intake a resident, part of the intake is asking whether or not they use tobacco products?
That I cannot answer if it's part of the
I'm just trying to get to where does this perception come from?
So part of the selection of these two partners to work with is also based on these entities have supportive services for their residents within their organization. So they are working with their residents across a variety of different issues. That gives a structure in which we can implement tobacco cessation supports, much different than an entity that might just be a housing unit in and of itself. There are supportive services within this model. So the structure of these two entities that work with their residents across a variety of issues gives us the opportunity to have kind of those critical structure pieces where we can bring cessation into existing infrastructure of these organizations, versus just trying to do it based on a building or based on a particular housing unit. That's really what drove the selection of these two entities.
Okay. All right.
Right, so the two organizations being Homeward Pikes Peak and Gracio Housing?
Gracio, yep.
Gracio, right. So they're the ones who know these units, the people they work with the best, to inform this program. So presumably, they would have the answer to this question. Could be worth just getting some more detail from them to help us understand.
I don't have our grant application in front of us, but
Okay.
we met with them extensively during that process and do have some data. They weren't just picked at random. We do have, data that supports working with low-income multi-unit housing properties that are offering case management for these people are seeking mental health services. They are dealing with substance use challenges, and so there is data to support that these communities need additional support, which is what we're trying to do and why we're partnering with them specifically. Because we know, based on data.
And The first stage will involve data assessment in partnership with these entities.
Yes.
The beginning stages will address these particular questions.
Commissioner Gardner.
Yeah, so I appreciate all of the questions, and I would say because we are approving funding today, I'm comfortable with moving forward with this. I think that there's some really important questions that are being asked about how it will be implemented. And I understand that, at the beginning phases, you're going to work through all of us designing the program, but we have to get those funds in so we can begin that work. But I would say I would also be very interested at a future meeting, once we've had some time with this, to talk about what a timeline looks like, how baseline data is being established. I noticed that you do have in here that, what you're trying to accomplish is obviously getting more people to enter into these services, and then to increase the duration. I don't know what that's going to look like in terms of how you're going to design that. Is that, we're going to do a check-in at 6 months, we're going to do a check-in at 1 year, or whatever those things are. I think that's the detail level that we're interested in, and I think it would be great to have that. What is the timeline? What can we expect going forward? What are those outcomes actually going, how are we going to know if we're meeting those outcomes? Are there goals being set for this program? So to know how many people do we think are likely, using tobacco, and then what are our hopes of getting, and our goals of accomplishing, and making sure that we're not just counting contacts, although I do think contacts can be a part of, how we reach those goals, but not just counting those contacts, but actually, how many people are actually getting to the outcome we want, which is actually quitting, right? And so I just think we're interested in that data, and I don't know that you can answer all of that today at the beginning of approving the grant, but I do think at some point if we could get that and see how that's working, so that when we come to this grant the next time, we have some idea of, is this working, and do we have the data? And I get the concept of evidence-based strategy. We know they work somewhere, but the real question is going to be in the implementation in my mind, right? So yeah, the strategy might work, but how are we implementing it, and how does our local data tell us that we're implementing it correctly and getting to the outcomes that we want? So I think that's what we're probably all looking forward in the future.
Yes, and absolutely appreciate all the questions, and we look forward to coming back with that information, and we will be working with an evaluator at the State Health Department, because they're very interested in these outcomes as well, because they're using this funding and us implementing this work to learn from this. So that's our goal, and so we look forward to coming back.
Great. Commissioner Nelson?
I thought of a follow-up question. Is this grant dependent on us staying connected with Greshio and Homeward Pikes Peak, or if we learn of another organization that has, a similar population, can they also be included? I'll let you answer that, and then I have a follow-up.
Okay. I think for this funding, we will be concentrating only on those two. Now, if there were an additional multi-unit housing, affordable housing organization that was interested in working with us, then I think we would utilize some time and effort with our core grant funding and the rest of the team. But these funds and this effort will be totally dedicated to those two organizations.
Okay, and then I guess I was wondering, I totally understand you guys are figuring this out, and it's really exciting that we have received these funds to do this work, and I just wonder if there is flexibility in that. If, for example, if we're struggling to find these cessation navigators and people stepping up to serve in this way, could we pivot and, again, like, we don't have to let the data tell us this makes sense. If we have a lot of children in these homes, could they then go into the schools that are in that area and, help with prevention, or if there's high school students that are using, is there some flexibility in how this might look? Because I hear the word innovation and I'm thinking like, okay, like we could explore different options if we're headed down a path and it's just not working. Can we pivot?
Yes. The short answer is yes.
Okay.
I think throughout this process, we're going to be continually evaluating. So, okay, we tried this, it's not working, we can't get a resident, they have too many other stressors in their life to be able to help someone else. So that happened to us before. And so it's constantly like process evaluation, looking at this is working, this isn't, how can we shift, what are we learning from this? So, yes.
Okay, great.
Yeah, go ahead, please.
Okay.
And I just want to add, through our conversations that we had just within the last couple of months with both of these organizations, like separately, they both run summer programs and other programming throughout the year for their youth around life skills that encompass everything from, financial health to substance use to mental health and so forth. And so we have recognized that there may be additional opportunities to engage with the youth around substance use, not engaging it with themselves. But again, we're like in the beginning stages and seeing where this could go. But the focus on the youth, I think, is definitely an option that is worth looking at.
Okay.
Great.
I'm sorry, go ahead.
So just so I'm clear, it's a 3-year grant or opportunity for renewal over 3 years at roughly $200,000, depending on our state budget. And I'm going to ask this of all of the contracts. Is there any matching requirements from us?
There is no matching requirement on any of the contracts that we
Okay,
have before you
perfect.
today. And I would just add as well, to your question earlier about new staff, none of these contracts require new staff. We may shift some internal FTE, but none of them represent additional FTE to the agency either.
Okay, thank you.
Yep.
Great. Commissioner Guyton?
Yeah, so I just wanted a follow-up of a differentiation on a question that Commissioner Nelson asked. When she asked if there's someone else that comes online that's not Gresham or Homeward Pikes Peak, can we pivot? And I want to make sure I understand, were you saying that's not the intention or that that's not legally allowable by the contract?
That's not the intention. I'm sure, like, if something fell through with one of these organizations, we would have the flexibility to work
Okay.
with another. But I'm saying we wouldn't just, if someone approached us and said, hey, we need help, we want to work with, or, we need your support, we're going to support them, just not with this innovative funding.
Got it. I just wanted to make, there's a difference between, this is what we were hoping to do, but also we do have flexibility if we need to go a different direction for some unforeseen reason at this time. And I wanted to just have clarity on that, so I
Yes.
appreciate it. Thank you.
Great. Dr. Collins?
I think a motion is what we're looking for here. But I think in the future, either monthly or quarterly, you can see all the questions we have, just an update of how things are going, where you're going with numbers, context, things like that.
Absolutely.
And anybody else who's presenting later on this list, that if we start getting into a lot of questions, we know that there's going to be more feedback required in the future. But I think to get the motion approved would probably be more expedited. But yeah.
Sounds good to me. Yes, I agree. So I will welcome that motion in a second.
Oh, I think he motioned. I'll
Okay.
second.
Motion to approve.
Motion to approve this funding as presented. Is there a second?
I was saying I'll second.
Okay. All in favor, say aye.
Aye.
All opposed? Okay, motion passes unanimously. Thank you both.
Thank you.
Okay, now we'll move on to our next grouping of contracts. These have been already approved. Can you just give us the overview again?
Yes,
As a reminder?
so these two are 100% federal dollars. So we do not have the final contract yet due to state contracting waiting for those federal dollars to be released. So we are bringing forward the draft to request your approval that when we receive the contracts in July, we can approve those contracts and sign those contracts that support our emergency preparedness and response program. In the event that the scope of work or the budget changes from what we are presenting today, then we will need to come back to the board with that updated information. But to not delay implementation of those contracts, we're asking for that conditional approval today.
Understood. Okay.
Okay, good
Go ahead.
morning. My name is Janelle McNair, and I'm the acting Division Director for Disease Prevention and Response, which does include the Emergency Preparedness and Response Program. So the contracts that I'm presenting before you today is the Public Health Emergency Preparedness, also known as FEP, and the City's Readiness Initiative, CRI grants. These are under disease prevention and response. And the funding source, as Dan mentioned, is federal funding. The fiscal year 27 FEP award is $589,960, and the fiscal year CRI award is $170,898. We are currently in year 3 of 5 of both of these contracts. There's no match required, and both of these contracts cover 100% of the emergency preparedness and response program. The purpose of the contract is that it helps El Paso County Public Health maintain our capabilities, our partnerships, and readiness that's necessary to manage public health emergencies. There are no changes to our grant requirements or goals from the previous years. Our program goal is that we strengthen the ability of El Paso County Public Health to prepare for, respond to, and recover from public health emergencies and disasters that occur within our community. And our core activities include leading public health emergencies through incident management, developing and maintaining our emergency response plans, and conducting trainings, exercises, and continuous quality improvement. We also coordinate emergency support function 8 activities, which is the health and medical component of emergency response through Pikes Peak Regional Office of Emergency Management. So our local impact and why this matters for El Paso County Public Health is that it supports coordinated response to disease outbreaks and other threats that impact community health, and it also enhances collaboration and communication amongst our healthcare systems, our emergency management partners, our first responders, and our community partners. Our value to our community is that it protects the health and safety of El Paso County residents by strengthening our local preparedness, our response and recovery capabilities for public health emergencies and disasters. Are there any questions from the board that I could answer?
Any questions? Okay.
Okay.
Thank you. Summer, I think you're up next.
All right. Hello, hello. I'm back. Summer South, Clinical Services Division Director. And I'm going to be presenting on several contracts at this point, so I'll stay up here for a little bit longer this time. All right, so we are going to start out with the Congenital Syphilis Prevention Grant. If anybody's following along, I'm going to start out on page 44 in your packets. So, we have a new name. This is now the Syphilis Screening and Treatment Clinical and Non-Clinical Grant. It's a mouthful. This falls under the Reproductive Health Clinic in Clinical Services Division. Our funding details, both state and federal. The total award amount is $421,195. This is contract year 3 of 5, and it covers 100% of the program. So the purpose of this contract is to address congenital syphilis infection and to prevent new cases in El Paso County by screening, also known as testing, and treating syphilis and other sexually transmitted infections in high-risk persons in El Paso County. So with some of the updates, so new name, and the new name comes from combined funding. So this grant now combines the STI contract, which we previously presented in years past, with the Congenital Syphilis Prevention Grant. And this really helps streamline and create some efficiencies within the treatment of STIs. And then because of this combination, the statement of work has been updated, and that expands screening and treatment efforts for all the STIs, including syphilis, obviously. Program goals. So to reduce the acquisition and spread of STIs, including syphilis, in El Paso County through education, prevention, testing, and treatment services. Our core activities look like administering STI testing and treatment in clinical and non-clinical settings. So this looks like our Criminal Justice Center, the CJC, our Reproductive Health Clinic, and community settings to include field-delivered therapy. We provide education on the prevention and treatment of STIs STIs, provide referrals and connect participants to community resources, and improve reproductive health and help prevent infertility and negative birth outcomes by screening and treatment of STIs. And, you know, just as a reminder, some of the negative birth outcomes with something like congenital syphilis. Oh, I'm sorry, I should probably redefine congenital syphilis. So syphilis is when the individual has syphilis infection. Congenital syphilis is when the pregnant mother passes it to the baby, and then the baby then has syphilis as well. And those negative birth outcomes look like anything from bone malformation, mental, I'm trying to think of the appropriate word, but mental conditions that make cognitive impairments, there we go, and all the way up to stillbirth. So pretty significant negative birth outcomes in congenital syphilis, as well as other STIs, but very seriously in congenital syphilis. All right, so local impact. This expands STI education, prevention, and testing and treatment services for our community. It supports detention center screening, community outreach, and field-delivered therapy. Screening in the CJC is a benefit to public health, allowing access to the highest risk populations and helping reduce cases of congenital syphilis. It improves access to early diagnosis and treatment to prevent congenital syphilis. So with the supporting data, I wanted to speak to the decrease in congenital syphilis cases in El Paso County since the implementation of this program. You know, I want to respect people's time. We have a lot of contracts to get through. You do have a companion document, a handout, that has some congenital syphilis data on here. And, you know, I'm happy to walk you all through it, but maybe it would be better served if you guys could take a look at that. And then if you have questions at the end, please feel free to ask. We're really excited about the program, so, you know, happy to talk about successes within it.
So if I'm reading this correctly, it's good news
Yes.
that the curve is going downward from the spike in, well, I guess it depends on which year and which chart.
I can explain that. But
Give us a quick overview of this real quick.
Absolutely, not a problem. Okay, so on that first page, you see the congenital syphilis cases in Colorado versus El Paso County. We trend pretty online with the state of Colorado, but one of the reasons we implemented this program is because El Paso County itself, amongst a couple others, was a hotspot for congenital syphilis case increases, okay? And so in 2023, if you look at it, we have El Paso County has 9 cases. We've really spiked. We implemented this program in December of 2023. So when looking forward into 2024, we see a decrease in cases to 3 in El Paso County. And then 1 in 2025, and currently preliminary data as of right now, 2026, only 1 case as well. So El Paso County, we are seeing a decrease. In the state overall, we are as well. However, there's a little bit of lag time, and it's accounting for all the other congenital syphilis cases that account for the cases in the state. So I just kind of wanted to snapshot that. And I want to also say that just because we implemented this program at the end of 2023 and we've had success in our case rate, it doesn't mean we take ownership of all of that. There are a lot of other factors that play into this, and we can't say correlation equals causation, but we do know that there's a synergistic effect when things like public health orders come out for increased screening for pregnant women during their pregnancy, and other areas, the education and support that is going out to community providers on an old disease that maybe, you know, kind of got dusty over time and people weren't exactly looking for those. So there's a multitude of reasons there. And then if you look at the pie graph, Agency of Diagnosis of Syphilis in El Paso County in 2025, it's on that first page still, just underneath the one I talked about. We wanted to highlight the fact that in all of El Paso County, the combination of the Reproductive Health Clinic and the CJC program in which we implement this grant account for over half of diagnosis and treatment of syphilis in the county. So we are really seeing quite a large snapshot of the highest risk populations, which is hopefully what is making this a big part of what's making this program so successful in decreasing congenital syphilis rates. If you flip it over, this is just the trend line, and I was wanting to give you all just a bigger snapshot of syphilis from 2018 to 2025 comparatively. And again, you can see that in Colorado, the cases are now finally starting to decrease, but in El Paso County, once we implemented this program, we're seeing a pretty stark decrease. Small numbers, big impact, understood, but overall, it is making an impact. So that's all this data.
Thank you for a really good presentation. The graph that you provided is very, very informative. I have a question about the program and the expansion.
Sure.
I understand that in 2023, or at the very end of 2023, when the program was first implemented, one of the target populations were incarcerated women, right?
Yes.
And I understand from the beginning of that program that you had partnerships within both the incarceration system and within the community to do some contact tracing and treat the partners of the infected individuals so that there would not be ping pong effects, right?
Yes, and in the very beginning, we could only treat the partner of an infected individual if they were also incarcerated at the time, but that has changed.
Okay, so now you're able to contact trace and treat the partner even if they're not incarcerated?
Yes, but there are nuances and details to that. And we've got Jamie here. She is the division manager for Reproductive Health Clinic. And she can speak a little bit more in depth to what that looks like now. And it's some pretty exciting developments. So I'll let Jamie speak to that.
Well, before she speaks, because she might be able to answer the next question also.
Absolutely.
In terms of the expansion into STIs generally, what proportion of your contacts now, patient contacts that is, for screening and or treatment are men?
So again, I'll have Jamie speak to that if she can. I don't know that we have the numbers off the top of our head, but she can speak a little bit more to it. And I also wanted to clarify something too. In the initiation and outset of this program, we didn't just test and treat for syphilis. We did test and treat for all STIs, but the expansion looks more like our population base and the funding that is associated with that. So. Jamie, you want to?
Thank you. Hi, good morning, Jamie. So to answer your question, with the contact tracing of partners and things like that, our health department does not do the contact of partners and investigation that way. That's done by the state health department. So when we do find a patient that's incarcerated in CJC who does test positive for syphilis and needs treatment, we're figuring out partner information, but then we relay that information and report it to the state health department that's required to do, and then they go and do the contact tracing. So if the partner is incarcerated, we will screen and treat them right then and there as well. But if they happen to not be incarcerated at that time, the disease intervention specialists from the state health department make that contact with the partner, and then they usually refer them to the reproductive health clinic to come get seen and treated that way. Does that? Yes, and then we do offer field delivered therapy, which is for the highest risk population who has significant access issues to health care. So if somebody higher risk, like a woman of reproductive age, especially a pregnant patient or a partner of hers, if they're unable to make it into the clinic due to different barriers, this funding also allows us to go out and to do field delivered therapy to ensure that they are getting the treatment that they need to complete therapy to help decrease the rates as well.
And so since you get the referrals to the reproductive health clinic for treatment of individuals that have been traced by the state, have you seen at least as many individuals coming to the reproductive health clinic to receive treatment relative to the number of women that were diagnosed with syphilis? Because obviously she had to have at least one partner from whom she contracted syphilis.
Right.
And she may have additional partners that she then infected. So you would expect that there would be at least one partner per diagnosis. And have you seen that?
It just kind of depends, because sometimes the partner may be in Denver, and so our clinic is not the most feasible location for them. So, I mean, we do see a lot of their partners, but I don't know if I could specifically quantify yes, we have one positive syphilis case and we have the partner. if that makes sense.
And then I think the chart was showing that CJC had 26 positives, right?
Yes.
So are those 26 unique individuals, or are they 26 cases in which some of them could be the same person who got reinfected?
I believe that the data that supports in that one, and I can look into it further, but I believe that the data that's in that one is these are new syphilis cases that we provided treatment for. Non-duplicated, yes.
Okay. Okay. This is a fairly expensive program when you're looking at just prevention of congenital syphilis. It's coming out to about $15,000 per prevented case if you're looking at the 26 cases. I don't know if those individuals were pregnant, but I guess they could potentially become pregnant. Although I would say that it's definitely worth the cost, even though it's so expensive, because a single case of congenital syphilis is so expensive. And I am gratified to see that our numbers look good, because we have a very large population relative to the rest of Colorado, and it looks like that things are going well.
Yes, and I do want to highlight a couple things within your statement there. One is that this funding also encompasses the lab testing credits that we utilize in the reproductive health clinic. So the non-clinical branch of this funding is what supports the detention center screening, our community outreach events where we're doing STI screening in a non-clinical setting. So we're doing STI screening, actually providing direct services at these community outreach events, trying to reach more of the population that are not incarcerated. It supports the field delivered therapy, so that's the non-clinical side. And then the clinical side of this funding is what supports our ability to say that we offer free STI testing for patients without insurance. So it's almost like credits from the state lab to do the testing that we do here in the clinic for patients who don't have insurance. So that both of those funding sources are now encompassed into this one grant too, which is a little bit higher than what we've previously seen. And I just want to make sure that we're clear on why that's reflected as well. One of the other big points too, and Chief Prem, correct me if I'm wrong, but in our detention center, we're one of the largest detention centers in the state as well. So I think that on average there's about 1,200 to 1,400 individuals incarcerated at any given time. And out of those, I would say about 200 to 300 are female. So we realize that there still is a large population of males that are not getting screening. So with some of the increase in this funding, we were able to split another FTE and to offer more capacity to do screening for males too. So they've rechanged the statement of work, not just to specifically testing women of reproductive age, but to testing a high-risk population. And so we can do testing and screening for men as well. So we're trying to expand our efforts in there too, just to support the work they're already doing in the detention center.
I'm very gratified to hear that, because obviously, the women are kind of half the problem.
Right.
And I recognize that that there were some changes in recommendations regarding screening during pregnancy, but I will say that the screening during pregnancy has never changed. ACOG has always advised screening for every single pregnant woman. I think that this program is effective because most of the congenital syphilis cases, as you probably well know, are people who did not receive prenatal care. And so this catches at least a high-risk population that did not see the regular screening that they would have gotten through prenatal care.
Right. This public health ordinance now holds ERs and other medical offices to the standard of if a pregnant patient comes in, they have to be able to offer STI testing specifically for syphilis. And it also increases the frequency in which it's offered during pregnancy. So it's not just at the initial prenatal appointment anymore. It's at the initial prenatal appointment at 28 to 32 weeks when you're getting additional lab work, and then again upon delivery or upon admission to labor and delivery for delivery of the baby, or if there's any sort of stillborn or anything like that, around the 20-week mark, they initiate testing then as well.
Great. Okay. Any other questions on this one? Oh, go ahead, Commissioner Geithner.
I just want to say thank you for a really great presentation. I agree, this was really helpful, and we asked a lot of these questions last time around this grant, and so this is fantastic. The only additional thing that I'm a bit curious about not necessary today if you don't have this information, but we have a comparison with the state, but it would be really interesting to see a comparison with the large counties as well, just so we can see where we are. Because as I look at this and I say, well, there's still 56, cases. Are those spread out, or are they all in Denver and, like the bigger counties or whatever? Just to kind of get an idea of how we are comparing as the largest county and what's going in other locations, and whether they are running similar programs or not.
Yes, yeah, some of the counties that are doing similar work to us, it would be Pueblo County, Jefferson County. Arapahoe has now started doing some work in the detention center screening world as well. So I'd be happy to kind of gather some of that data to also present.
Great. Thank you.
Of course.
Great. Okay, thank you. Summer, I think you have 3 more.
Thank you. Yes, I've
Continue
got more.
on.
And we could go on and on about this. So there's like cherries on top being SMEs, but we'll move on. Okay, so let's reorient here. All right. So our next contract, immunization core services, and that is page 53 in your packets. So this is our LPHA immunization core services. It is housed in our immunizations program. And this is state and federal funding. Right now, what we're presenting to you today is just the state portion with anticipated federal funds in July. And it's only partial state funding as well. This was so that we could continue the work without a break in service. So award amount, current partial state funding is at $169,022. This is contract cycle year 5 of 5. There is no match required. And the percent of the program that this covers is approximately 30% using our predicted funding amount. So we're taking into account the anticipated additional funding from both state and federal in July. And then looking at the other portions of this program, also largely supported by our clinic fees that we bring in at a roughly 30%, and the rest being agency funds at 40%. The purpose of this contract is to reduce vaccine preventable diseases in Colorado by increasing access and providing education and alignment with national immunization standards. There we go. So updates. This is amendment of the current contract with partial state funding, as we just talked about, and with that anticipated additional funding in July. There was a decrease in deliverables for the statement of work due to the anticipated decreased funding. However, the actual project itself, the structure of the statement of work, none of that has changed. Our program goals is to reduce vaccine preventable disease in Colorado by increasing or maintaining immunization coverage in El Paso County. Our core activities involve offering, promoting, and administering immunizations to those who are interested within our jurisdiction. Oh, okay, there we go. So looking at local impact, this funding helps us to serve clients who choose to follow an alternative vaccine schedule, who are uninsured and underinsured. This funding helps us to be a resource for questions from school nurses and individuals within the community. This funding aids in the response to emerging issues in the community through the use of our disease response team. And looking at some of the supporting data in 2025, the immunization program responded to the measles outbreak, hepatitis A, and administered rabies post-exposure prophylaxis. And in 2025, the program served 4,307 clients. And that's it for our immunizations. Any questions?
Any questions from the board? Commissioner Geithner?
I noticed under the purpose that it is listed as increasing access and providing education and alignment with national immunization standards. So can you just speak to what is the national standard that we're looking at? There's a lot of debate about this right now, and I'm just curious, what is the standard that we are applying?
Sure. I'm going to have Christy come up and speak a little bit to this. We've been having lots of conversation, of course, around what this looks like and alignment therein.
So for our clients, when a parent comes in, we allow them to follow the schedule of their choice, whether that is the CDC schedule that's been approved by ACIP, or the American Academy of Pediatrics schedule, or the schedule that they have decided with their pediatrician. So that's kind of where we align there.
Offering choice.
Yeah, offering choice, yes. Mm-hmm.
And being able to, I'm sorry, over here. And being able to speak to them as well, if individuals have questions, encouraging consultation with their pediatrician, especially around, the pediatric vaccine schedules.
So are the 4,300 clients, are those children mostly? Can you provide some more color on
So I don't have
that?
the breakdown specifically of appointment type, but that is all of the appointments we have seen. So that could be a child, that could be an adult, that could be a travel appointment. That's the total amount of appointments that we saw.
Okay. Okay, any other questions? Commissioner Geithner, go ahead.
So I'm a big fan of choice, and I appreciate that that's what we're doing here, but I am curious, because looking at too, and I know that you said that some of this is partially federal funded, so does the federal funding close the gap on the total program?
No. So what Summer had mentioned earlier is this covers about 30% inclusive of the federal funding add-in. About 30% of it is covered through fees that we collect, whether that's through insurance billing or other payments, and then the balance is made up with agency funds.
Okay. So I do, just kind of thinking through this as we talk about, we want people to have choice, but taxpayers are paying for this. So there does come to me a point where we're going to say, like, we're going to give you required things or necessary things. We're obviously not going to say, hey, if you want 12 tetanus shots, that's cool by us, right? And so obviously I don't think that's what we're doing, but so I am just kind of thinking through, we have a lot of different standards there, but there are necessary ones. And so, I mean, is there a point that we need to say, you can't just pick any standard, right? There's got to be some level of, ASIP is one, and I know there's a lot of controversy over this right now, but it is interesting to me because it could end up costing us a lot of money if we have standards where we're going with the World Health Organization, which I know Colorado is a really big fan of trying to get away from anything in our national government right now. But the reality is I want people to have access and to have choice. At the same point, we are paying for this. So at some point we have to say, if you want beyond, over and above what, is the national standard, which is ASIP, I think at this point, I would argue, then are we providing those at free or no cost, or are we saying, like, here's what we provide as our base level? And so just, again, I'm in support of this today, but those are things that in my mind I'm really thinking through, because again, we want to have choice, but we also wouldn't say, sure, take 12 of this. That's not what we want to do either. I'm not saying anyone is encouraging that, but just there are various levels of what should be. I mean, COVID vaccine is a really good example, which is very controversial. It's no longer recommended for a lot of people, but are we still saying, even though it's not recommended, are we still saying, but we'll pay for it anyway, even if it's not recommended? And at what point are we saying there is a cost associated with these things, and so we are providing what we believe is necessary as a government service? If you want more than that, you're going to have to figure out on your own as a personal responsibility piece.
I would also say that there's kind of already two limits already in place. One of them being our 317 vaccine for uninsured adults. We get a very limited amount from the state. Sometimes we get 10 doses for the month. So there's already a limit there. If somebody does want that, they have to pay the full price out of pocket. So that limit is in place. And then also we run under the standing orders of our medical director. And so there's no way that we could give someone 12 shots without talking to him first.
Let's hear from.
That was kind of a facetious example there, right? About choice, but yeah.
Paul Mayer, medical director of El Paso County Public Health. So I'll mention that you're right. We had to look at all the guidelines coming out and make some decisions. Some of it is, a lot of people come in and they really don't read a lot, and they're not well informed. They're like, I got a 4-month-old giving the shots I need, so what shots do they need? So the school guidance can become a default, and so we can tell people, gosh, if you don't want to sign a waiver, we would recommend you follow the school guidance, because that's going to allow you to not sign a waiver and go through that process. The other thing to mention is there's some semantics involved. So if something's recommended in medicine, it means you should do that to be a good provider of medicine. But it doesn't mean that if it's not recommended that you shouldn't do it, if that makes sense. So if somebody comes in and something's not necessarily recommended, but it's allowable per the guidelines, per patient choice, we will usually default to patient choice. If something's not recommended, then we don't do that. We say, no, we're not going to do that. So that gets into the 12 tetanus shots. That's not recommended, so we're not going to do that. But if somebody says, gosh, I want a COVID shot, and they're not in a group that says you should get this shot, but you may get it, we would say, well, sure, if it's allowable, you can do it. But if it's not recommended, then we'd say, no, we're not going to give you that
Right,
shot.
and I can understand that from a perspective of patient choice when you are paying the bills or it's your insurance. I think it's a bit different when the government and the rest of the taxpayers are. So I guess that's what I'm getting at is I think it's important for us to think about what is recommended, and if it's beyond what is recommended, and that's going to take away from some other person's ability to maybe get some care from our system, then we might want to think about that.
Sure.
Is I guess what I'm really getting at, because one person getting everything that they want that's not necessarily recommended could lead to someone else missing out on what are the basics of care or the recommended care in that situation, because funds aren't unlimited for anybody. So just food for thought on how we, might deal with that. We want choice, but also when you're not the one, when taxpayers are footing the bill, we've got to figure out how to spread that amongst our most vulnerable population and make sure that they're not getting that. So.
Sure, no, that makes sense.
At this point in that example, is it really only the COVID vaccine and flu? Like, what are the actual scenarios? Or if I'm opening up a can of worms, we can move on.
Because with the new guidance, it actually becomes very complicated, to be honest, because it's vaccine by vaccine, to be honest. And so there's a lot of leeway now because of the change in the guidance from the federal government, like with HPV, with hepatitis B. Now it's become, to be honest, it would be a very long conversation to go through each one and explain those variations.
Okay. Well, then I think Commissioner Geithner's point is well taken, as is yours response. So I'm okay with leaving it at that for now. Okay. Oh, Commissioner Nelson.
You mentioned school guidance. Is that at a state level that is being set for schools, or is that local? Like they're looking to El Paso County Health?
Right early on, the schools aligned with the American Academy of Pediatrics guidelines, because admittedly there was a lot of confusion, for a while, and I think a lot of people just wanted to know sort of, to your point, what is sort of the right thing to do?
Yeah.
And that became very confusing, so the schools aligned and the state aligned with the American Academy of Pediatric guidelines.
So Colorado Department of Public Health giving the guidance to the schools?
Correct.
Okay, thank you.
Dr. Chan.
Could you delineate where the boundaries are between this immunization program and emergency response? Like, for example, if there's a large hepatitis A or B outbreak or...
Sure. So our day-to-day operations is, having our clinic down the hallway offering, kid adult vaccines. But if we have, say we have a case of measles, then we try and just deploy our disease response team to respond to that. Those are like basically PRN staff that we can just pull for that. They would just do that. We can keep our brick and mortar operation still running, still serving those clients who want to be served. But if it grows, then we start to have to pull resources from our clinic to be able to respond to that. But with our measles outbreak last year, we were able to keep this whole operation running and run a measles response effort as well simultaneously.
Okay, so if there's just a few cases, then you do the response, and that's part of the immunization program, whereas if you have a declared outbreak emergency, then that goes over to emergency response?
So I could speak to that a bit. When we have a mobilization of our team for a time-sensitive communicable disease outbreak, we go into incident command structure. So our emergency preparedness team comes alongside our immunization program. They are providing planning support and logistics support, while Christie's nurses deliver the vaccine. So it's a complementary effort. Yep.
Okay, thank you all. That was a great discussion.
Thanks, guys. Appreciate it.
I think we're on nurse-family partnership now.
Yep.
Okay, go ahead.
That's where we're at. Okay. All right. So next up, page 59 in your packets. is our Nurse Family Partnership. So this contract title is the Nurse Home Visitor Program, but we call it Nurse Family Partnership. It is housed within our Nurse Family Partnership Program in Clinical Services. And this is the one that is funded by the Colorado Department of Early Childhood through the Tobacco Master Settlement Fund. The award amount for this year is $1,667,218.82. And this is contract cycle year 1 of 1. This is renewed every single year, signed a brand new one every single year. There is no match required, and it covers 100% of the program activities. The purpose of this contract is to provide home visitation by registered nurses to eligible first-time parents from pregnancy through a child's 2nd birthday. All right, so there were no changes to the grant requirements or the goals. The program goals are to improve pregnancy outcomes, to promote healthy child growth and development, and to improve economic self-sufficiency of the families participating. Core activities include registered nurses visiting enrolled families in their homes every 2 weeks, and to provide education on topics of nutrition, pregnancy, labor and delivery, infant feeding, child growth and development, and goal setting. Oh, no. All right, local impact. So this funding allows the Nurse Family Partnership to serve approximately 200 to 280 El Paso County families per year. NFP nurses are often the first to identify health, growth, and developmental concerns in enrolled children. And then I was going to speak just a little bit to the supporting data. So of the 120 infants that were born in 2025, 94% of NFP clients initiated breastfeeding at birth. And then when we're looking at the 100% of El Paso County clients reporting a decrease or cessation of tobacco use from enrollment to 12 months postpartum, that's of the individuals who reported smoking in the first place, right? And so that number is actually 5. So it's good to see that only 5 of the clients did that, but I didn't want anybody to think that it was the 120 families and it's 100% reduction. Wowza, it's 100% because there were only 5. And that's also fantastic. Even one person reducing is great, but I just wanted to be very clear about those numbers. And then looking at the 76% of enrolled NFP children received a comprehensive developmental screening at months 4, 6, 10, 18, and 24, which are the recommended timeframes. And that number is out of 165 families, and that, again, has to do with the ebb and flow of families being born prior to 2025, graduating after, and where they fall into that in terms of ages 4 months, 6 months, 10 months, and the retainment in the program. So again, each of these percentages have a different N, a different number, and I just wanted to be really clear about that. So, and that is our NFP.
Even with that exclamation on the 76%, that seems a little low to me. Is that the overall across those months? So would 4-month cohort be higher and then it kind of decreases over time, or?
I mean, that's a great question, and we've got Kara Hamby here. She is our division manager for the Nurse Family Partnership Program. I highly doubt we have the graduated percentage numbers, but she'll probably be able to speak better than I can to this.
And my general question is, if these are home visits, why is this not closer to 100%?
It's a great question. So this number encompasses the number of children who received all of those screenings. So for many families, we don't see them for 2 months. Someone's incarcerated for 6 months, something like that. So these are the children who we were able to capture that data at all of those time points. I would say 100% of the children involved to get a screening out some of those time points.
Okay,
Mm-hmm.
That's helpful. Any questions? Dr. Jan?
Okay, so looking at this program, I think that our previous discussions, I made it clear that it does appear to be very woman-centric. And of course, when we're looking at a family, I'm thinking that there's probably some other half, another component to the family. And I understand from our previous discussions that sometimes it's difficult to draw in the partners because of domestic violence concerns. But it seems that part of achieving the goals of of this program is helping people get off the hamster wheel of poverty and dependency. So is there any component of this program that helps the women that you are interacting with or other family members of the women to make more prudent and constructive choices in terms of partnership with the fathers of their children?
Yes, so we are registered nurses, right? So we are medically trained. A lot of what we do is also falls into the realm of social work. So providing resources, community connections. We also do a lot of work with families about healthy relationships, goal setting. We'll do a resume with someone. We will help them get into housing. It is a significant amount of what we do. I would say in terms of your question about pulling in fathers, it is something certainly that is ideal, right? It's ideal for the father to be present at a home visit. It is rare that they show up. So, of the number of clients that we have, most of our visits are with the mom because that's who delivered the baby and that's who's present. That is who we enroll, and that's how the program is designed. There are many other programs that are designed for fathers specifically. Family members are, of course, always invited to our visits. So sometimes someone will bring their grandma to their visit. Sometimes they'll bring their best friend or their neighbor. Fathers are always welcome. I can't say that it doesn't happen a lot.
Well, I understand that a lot of times, if there is a father in the picture, if your visit is during the day, that they may not be able to attend because of work commitments. But I think that my question really focuses more on strengthening the decision-making in terms of healthy relationships and choosing an appropriate partner who will help her build a strong family. Is there intervention in that regard?
Sure. Yeah, there's lots of education on positive relationship building, cycles of trust. We are dealing with a lot of families with significant trauma backgrounds, so it's a complicated. It's a complicated process. So yes, it is something that we do. It is not one of our, it's not one of our objectives, but it comes up a lot.
And referrals to mental health services.
Absolutely.
If they, need it to help work through that. And I think just to say something to that piece, again, we are registered nurses, like Carol is speaking to, and so we don't have the background and training in trauma-informed therapies and, getting women to move from this goal to this goal. Our focus is very much what we listed here in the objectives. However, they do have all of their training is trauma-informed, and we have referrals to services and encourage women to seek services when signs of intimate partner violence or other dysfunctional connections are made obvious. So.
Okay, Commissioner Geithner, and then Dr. Collins.
Yeah, I really appreciate those questions. I think it's incredibly important, and I understand that they're registered nurses, but you're also talking about improving economic self-sufficiency, and I assume nurses aren't, necessarily econ majors either. So we obviously, you have a broad scope here, and yes, very complicated situations with all of those things, and there's a lot here. But are we encouraging and explaining part of creating a good economic situation includes often having a family that has a father that is also participating in the family? Are we encouraging that? Even if they're not showing up, are we telling mom, hey, your child will be better off if they have a father in their life, considering they're not abusive and all of those things? Are we having those conversations?
Absolutely.
Okay, that I think is really important, because sometimes we don't like to talk about that in our society today, but we know the research is there on this and how important it is. And I will also say, because I have the unfortunate task of being the contact for fatalities at the county from DHS, we have a lot of situations where moms, we've got dads who are, the issue in the home in terms of those things, and so those healthy relationships obviously are critical for that child as well. You guys all know this stuff, but obviously it's very important. And so I'm just glad to hear we actually are encouraging that.
Absolutely.
And like, yes, we need that. We need nuclear families create strength and economic strength and all of those things. And I don't think we should be afraid, I don't think we should shy away from that. That may not be ideal or possible in every situation. And I completely also understand that, but to the greatest extent, at least being truthful about that is how we get to the most success for families, I think is incredibly important. So thank you for sharing that is happening.
Dr. Collins.
Thank you. Having spent last week with Summer, Aaron, Jamie, Christy, my confidence is high in all of these programs you brought here today. My concern is that, or question is that 280 families, that's your end, but the budget is 1.6. Compared to some of these other, is there plans to make it a more robust, or I don't want to say cost effective, but I don't really have a good endpoint, and it seems like a lot.
So
per
those are 200
family.
families who participate in the program for 2.5 years. So the average number of visitations that one family receives is 212 over 2.5 years. So it's a significant number. So the relationship building that happens within the context of that program for someone from pregnancy until their baby turns 2 is pretty significant. That 200 clients, each nurse carries a caseload of 25 clients. They're visited in their home every 2 weeks. And we travel to Cripple Creek and to Fountain and to Palmer Lake. So it's a...
And I'm sure you gave me all those numbers when we spoke last week.
No, you're fine. Yeah, and in terms of expanding, it would require a new grant. We are at capacity for the number of nurses that our site can support.
Okay. Oh, go ahead, Commissioner Geiger, go
Yeah,
ahead.
just because you just gave the numbers, I appreciate you asked that. So I was trying to do math here in public, which was really dangerous, but you said about 200 families and they're getting 212 visits per year?
No, over the course of the
2.5 years.
enrollment.
Okay, so we could say 100-ish in half that
In a
time.
year.
Yeah,
It's
in a year.
every 2 weeks.
Okay,
Ish.
well, then I can divide that. That's easy, right? So that gets us to 26 visits a year. I know, you guys are making me do math in public, and I am an English major.
So there are some nuance. They are visited every 6 weeks in their home, initially when baby is born, often more than that for breastfeeding challenges. Or
I'm just looking
postpartum
for a
recovery.
ballpark here, because we were talking about cost, and so I'm just curious about cost per
I think
visit.
it
Do you
sounds
have
about
that?
$80 per visit, right? I could provide you with the actual
Okay.
number of visits if that's something I don't have.
Which
off the
for an
top of my head.
in-home
It's a
visit by a
lot.
nurse
Yeah,
is a
it's-
deal,
Yeah.
Yes,
I think. And when we bring in the benefits of this program.
correct.
I think, and that was kind of my
Yeah.
point, is it does seem like a lot when you look at the families, but when you look at the intensity of the program,
Yes,
I think, yes, for a visit, those are pretty reasonable costs, so.
Commissioner Nelson?
2 questions. So you mentioned, a family member, that there might be a delay in a visit or a cancellation because someone's incarcerated or whatever. Can you give us a perspective on, of these 200, 280, the populations that we're serving as far as, because when I read through this, I didn't initially think that we were meeting needs for low income or incarcerated, but is that really who we're targeting here?
So the eligibility requirement for this program is that you must meet low income. So it's 200% of the federal poverty level.
Okay, I missed that.
And first-time parent, those are the 2 requirements.
Okay. And then when we're thinking about supports for breastfeeding and that sort of thing, is there then overlap with some of our other programs? Like
Absolutely.
WIC and
We
that
work
sort
very
of
closely with
thing?
WIC.
And so I don't know where I'm going with this, but just I imagine there's overlap there and.
There's a lot of overlap. And all of
Yeah.
our nurses are certified lactation counselors, so we can offer in-home breastfeeding support as well. And then most of our clients are also receiving WIC support.
That's what I was going to ask. So is it that someone might be seeing out of this program every 2 weeks, but then they're also on that off week getting services through WIC or, supports? So
Yeah, WIC services are much less frequent, but yes,
Yeah.
they could be enrolled in both
Okay.
programs.
Okay, thank you.
I promise this is my last question.
Go ahead.
So since you're only taking clients who are being a first-time parent, and then you're following them for 2 years, do you have, well, you probably do, the number of clients who then had a second pregnancy within the time that they were enrolled?
I do. It's around 25% by 2 years. Someone has a second child.
25%, okay.
Okay, thank you.
Thank you.
We can move on, Summer, to your last one.
All right, home stretch here for clinical services anyway. Okay, so next up we have our tuberculosis prevention and control grant, and that is on page 68. All right, so this is our TB prevention and control grant. It is housed in our tuberculosis program in clinical services. It is state funded. The award amount for this year is $60,000. This is year 4 of 5 in the contract cycle. And the percent of the program covered by this grant is 15%. The purpose of this contract is to provide funds that support all TB-related activities to prevent the spread of TB in El Paso County. TB investigation and control is a statutory requirement, CRS 25-4-506. There are no new requirements and no changes other than a slight reduction in the funding just due to all the budget constraints and, other funding formula factors. Our program goals is to screen for, test, and treat active and latent TB infection and prevent its transmission. Core activities include TB evaluation, testing, and treatment of high-risk individuals, contact investigations to stop the spread of TB, and then consultation and advanced testing for our local healthcare providers. Looking at local impact, the TB program provides expertise and serves as the only TB clinic in El Paso County. This program manages all TB activity in El Paso County due to the public health significance of TB. In 2025, we served 35 TB clients, both latent and active combined. This translates to over 1,000 directly observed therapy encounters for this team, and the average duration of treatment for TB is 4 to 6 months. So really small team, big impact, lots of in-person visits. Any questions?
Any questions on the board? Okay. Thank you, Summer.
Cool, thanks, appreciate it.
Okay, Daisha, bring us home with your 3 for community health.
Okay, so the next contract is our Child Fatality Review Team, and this can be found on page 76 of your packet. The 3 contracts I'm going to be reviewing are long-standing contracts that have been previously approved, so I'm going to, because of the interest of time, I'll try to keep it high level, but if you have questions, I'm happy to answer those. So this contract is our Colorado Child Fatality Prevention System. This is facilitated by our Injury and Violence Prevention Planner. This funding comes from the state, and the award amount is $27,000. We get this through annual renewals. There is no match required for this funding, and this funding covers approximately 25% of our Injury and Violence Prevention Planner. The additional funding to cover that her efforts are an additional 25% from our overdose fatality funding and 50% from agency general fund. The purpose of this contract is to review injury and violence related deaths among 0 to 17-year-olds to develop prevention recommendations that reduce child mortality from preventable causes. This funding also supports us in fulfilling our statutory requirement of the Child Fatality Prevention Act. There are no updates to this contract, and the program goal or the contract goal remains the same, to prevent
to develop prevention recommendations that reduce child mortality from preventable causes. Our core activities is to facilitate multidisciplinary review of all preventable child deaths in El Paso County and provide high-quality, timely data feeding into state and national prevention systems. Why this matters for El Paso County, part of that, our multidisciplinary team is made up of local experts that are informing prevention recommendations. So we work with the coroner, law enforcement, schools, Department of Human Services, and other subject matter experts depending on the type of death that is being reviewed. We get high quality, timely data from these reviews that we share with our Safe Kids Coalition, locally, that we share with our youth suicide prevention partners, so that can inform some of their strategy and effort moving forward as well, so that we're impacting local efforts, and again, our continued statutory compliance. Just wanted to highlight a value to our community. So this is an incredibly challenging effort to review child deaths. You mentioned receiving the calls, like the amount of detail that they have to review is very, very challenging. And so finding something positive out of that is always a great opportunity. And the number one cause of death in our community for 0 to 17 is infant sleep-related deaths. And so a recommendation that came out of the team was to start providing, we needed to provide more sleep-related education. And the deaths were occurring before 3 months of age. And so our team developed education resources, partnered with our vital statistics program, because we know parents are coming in usually before their child is 3 months old to get their birth certificate. So it was a good opportunity to reach a population at a critical time to provide them education. And it's really exciting that that model is being implemented in other areas across the state. And I think even outside of our state, we've been asked to, Emma's been asked to share information at conferences and things like that. So it's just something positive that comes out of a really hard thing that we do. Any questions about this contract?
Commissioner Carter?
Yeah, quick here on this. This is such a sad topic, but also an important one. So great, the opportunity to capture those folks coming in, getting birth certificates, and have that conversation. From my perspective, it seems like one of the overlapping factors is usually substance use in many of these. And so I assume that that is being incorporated in, and is there any overlap with any of our other type of, substance use prevention services here?
Yeah, I'm gonna let Emma speak. She's fantastic.
I'm so glad that you brought that up, because that's definitely a consideration that we had when we were creating that Safe Sleep Station in our Vital Records office. So in that Safe Sleep Station, we also have resources that connect families to how to sign up for Nurse-Family Partnership and our Baby and Me Tobacco Free program, because we were seeing a lot of that overlapping with substance use. And then we also have connections to the Maternal Mental Health Hotline, which is how moms specifically can reach out to substance use prevention providers.
Thank you. Any other questions?
Alrighty, we can move on to the next one. Thank you.
Okay. Next is our impaired driving prevention contract. This one is titled Community-Based Impaired Driving Prevention or Persistent Drunk Driving. This funding will be with our substance use prevention program. And so as I mentioned earlier, that program is made up of several grants. This grant specifically covers 8% of the program. This is state funding awarded in the amount of $100,000. We're currently in year 4 of 5 of this funding cycle, and there is no match required. The purpose of this contract is to reduce injuries and fatalities related to impaired driving by decreasing excessive alcohol and cannabis use. An update is that we are going to be taking a more upstream substance use prevention approach with this, because that's the underlying issue is the substance use before they're even getting in a car. We did see a reduction of $20,000 in supplemental minor and possession fine funds. That was due to state budget restrictions, but we did receive our core funding of $100,000. The goal remains the same, to reduce impaired driving injuries and fatalities by decreasing risk factors and increasing protective factors. With this funding, we are given a menu of strategies from the state, and we have to pick a foundational strategy and 2 supplemental strategies. Our foundational strategy is the hotspot mapping, which is really just us collecting data and analyzing and figuring out where are the needs of our community, where are the most traffic accidents happening related to alcohol or substance use, and so things like that, and then providing the community education focusing on certain areas. The supplemental strategies are information dissemination, so sharing what we've learned, sharing the data. And then our second strategy is community-based processes. So obviously with $100,000, and we can't solve the whole problem ourselves. So it's really important that we're working with our community partners, such as law enforcement, other substance use prevention professionals in the community as well. Why this matters for El Paso County, part of our chronic disease, or one of our chronic disease prevention strategies that we have chosen to move forward with is alcohol use, so this pairs really nicely with that. It'll just give us an opportunity to further implement strategies to tackle that alcohol use in our community. Some of the supporting data, in El Paso County, the rate of alcohol-induced deaths nearly doubled over a decade, from 15.2 deaths per 100,000 people in 2014 to 29.1 deaths in 2023. We did see an encouraging drop in 2024, but you'll see that that's still 40% higher than our rate in 2014. So we do have a problem in our community. Like I said, we are just a piece of that, but hope to be able to contribute to making that better. This grant supports community education and outreach, data analysis and sharing, as I mentioned, in collaboration with our community partners. Any questions about
any
this?
questions from the board? Okay, thank you. One more. Go ahead.
One more contract. So this is our core tobacco funding, tobacco education and prevention partnership. The contract is, and I apologize, this is on page 89 of your packet, if you're following along. This contract is titled Community Tobacco Initiatives of El Paso County, again with our substance use prevention program. This covers 72% of that program. This is state funding in the amount of $1,137,282. This was lumped into, like with our chronic disease and the multi-unit housing funding, our contracts came in at a higher number, but it will be reduced to that lower amount. This funding comes in 3-year funding cycles, so we are starting a new funding cycle, so this is year 1 of 3. There is no match required, and the purpose of this contract is to support statewide goals to reduce tobacco use and protect Coloradans from secondhand smoke and vapor exposure and expand cessation services. We did receive a 15% funding increase, and that was to expand the infrastructure and scope of our work within this grant. With the reduction, it will work out to be about a 10% increase, so still an increase. And then our goals remain the same, and that's to prevent chronic disease caused by tobacco and nicotine use by reducing exposure, supporting cessation, and connecting people that want to quit with effective resources. Our core activities, like I said, are to help people quit and connect them to treatment. We're not forcing people to quit, we're just providing information and making it easier for them to access. One of our big focus areas is preventing youth tobacco and nicotine use, trying to prevent them from ever even starting, and expanding tobacco-free policies and reducing secondhand smoke exposure in the community. Why this grant is important, it's one of our 3 leading behaviors attributed to chronic disease. And we were eligible for the chronic disease prevention funding because we have this grant. And it's because it's such a big contributor to chronic disease. Tobacco is the leading cause of preventable death in the United States. Our expected outcomes, again, this is long-term. We're a piece of, it's a comprehensive effort to tackle such a big issue. But we're hoping to see a decrease in tobacco use and youth initiation, which we have. You'll see in the chart over on the right here. Reduced exposure to secondhand smoke and vapor. Always looking to provide support for new and strengthened community tobacco-free policies. And we want to demonstrate progress in our community engagement and our evidence-based strategies. Like the chronic disease prevention funding, because that framework was built around this one, the first year of every new funding cycle, we complete a tobacco-focused community profile. And so that is really an assessment of our community, doing key informant interviews, collecting data, figuring out what's important to the community, where our problems exist, and then focusing our efforts there. And so we do that every 3 years, and we will be doing that at the beginning of this funding cycle. Any questions about this contract?
I just have a question about that chart. The adults who currently smoke, those are people who are using like cigarettes, right? It's two different things where you basically have 21% of adults in El Paso County use some kind of inhaled tobacco product?
I don't know. I would have to get with our data and analytics team to know if it's, if they're smoking, are they also vaping? Because there's dual use.
Oh, okay.
Do you get what
These are
yeah,
not
okay.
mutually exclusive
Yeah.
categories.
Okay.
Thank you.
Oh, so we don't know, like, yeah.
Did you want to add to that, or?
I do.
Oh, go ahead.
I was actually just looking at this morning, according to the most recent data. So our statewide adult smoking rate for vape and tobacco cigarettes is about 10% compared to a national average of, I believe it's about 18%. So we are the second, I don't want to say healthiest, but like we use tobacco and vaping at this. There's only one state ahead of us, and I forgot to look who that is. I'd have to look that up, but so again, I was just looking at this. So about 10% use cigarettes, combustible tobacco. Around 6 to 7% of adults use vaping products, and 27% of adults are dual users, as Daisha mentioned, which meaning that they use tobacco, combustible cigarettes in addition to vaping. So it's not mutually exclusive. Either people vape or they smoke cigarettes. A lot of times people are using both products. And then there's also smokeless tobacco, like the pouches and things like that, which fall into the vape category. So, and there's a lot of products out there, and it's very convoluted.
Okay, wait, let me make sure I understand. So overall, about 10% of the adult population uses tobacco products of any kind, but of that 10%, 27% use both.
Yes.
Okay, all right.
Yes.
Got it.
And there are wide discrepancies around that 10% appears low. However, when you look at certain demographics and groups, there's differences.
Got it. Okay, still doing pretty well.
Yeah. As a state, absolutely, yes.
Okay. Oh, go ahead, Commissioner Nelson.
I don't know if it's a question or a comment. I recognize the challenge of collecting data and notice the asterisks around the data with high school students, and it was dependent upon the Colorado Healthy Kids Survey, which a lot of school districts chose to opt out of. I was involved in that personally on the District 11 school board because they asked questions that were not just correlated with trying to understand the health of a student and their choices on nicotine use or alcohol use, but they veered off into other categories, and so it forced our hand to then pull out of that survey. And so I just wondered if you guys are thinking through how to collect data that is helping us understand the needs of our community without being so intrusive into individuals' lives or promoting ideologies, which was evident in the Healthy Kids survey. And is that something that you're continually having to figure out? And is there something that this grant money could help, and partnerships that we maybe need to be pursuing with local school districts?
Yeah, so definitely aware of the challenge there and understand. I think because that is a statewide survey, what we are doing is having those conversations like, hey, this survey doesn't work in our community, but we desperately need data. And so how can we work together? But it's really reliant at the I believe it's put on by the Colorado School of Public Health. Dan, you want to add to that?
And I was just going to add that this is a continual issue that we work with our data analytics team to help us look at other sources of data. We're also having conversations as we get ready for our community health assessment about what we could change in terms of data collection options. So I don't have a perfect solution for the gap around youth data, but I know between the conversations occurring with the Opioid Council, conversations occurring within our agency, there's a high degree of interest, and we have partnered in the past with some other entities to do more focused youth assessments that are more narrow in scope and targeted to issues. So I think it's a continuous work in progress as we try to find other ways to fill in the gaps. And the asterisk data that you see is we did extra work with available Healthy Kids data to be able to get non-representative samples to be able to come up with some estimates. That was also another data partnership that is different and apart from the typical survey.
Yeah, and I recognize the challenge, and I guess I just want to offer that if there's something that we can do to help support, or if you have some ideas but you need to come to us and request FTE movement or funding or whatever to help gain access to data so that we know if we're moving the needle on some of this really important work. And that's the thing, is like, this is important work, but we also want to know if we're making change and seeing the outcomes we're looking for. And so I just am offering, I guess, that I see that it's a challenge, and if you guys want to be innovative and come up with a way to get after it, like, hey, I'm all on board. And if it's in partnership with the Opioid Abatement Council or whatever, like, it's really important that we see if we're improving outcomes or not. And unfortunately, the Healthy Kids survey, I think, is just not an option at this time. Maybe they'll start walking back some of that, but if we need to go off on our own and create something that we partner with our local school districts to just help us understand, just putting that out there, that I'm open to that personally. I can't speak for the whole board, but
yeah, I wish we could, because not all parts of that survey are bad. And so, it would be nice if we could at least ask the questions that our county is interested in. So,
Commissioner Geithner, go ahead.
Yeah, I just want to follow up on that a bit, because Commissioner Nelson mentioned the Opioid Council and the work that we're doing there, and I don't know if everyone is aware of that, so I just wanted to expand a bit. And then I don't remember if there was a tobacco question when we went through it or not. There are definitely the other questions, and I know you guys are involved in all of that.
Are you talking about the survey that we
from
approved
Opioid
that's
Council
through social media?
Yes.
There was a tobacco and a vape question as well, I believe.
So we're already asking, and we should get that data back. So hopefully that can be there. And that was one of the things that we talked about at Opioid Council. So just briefly, that's obviously settlement dollars that are coming in. Commissioner Nelson and I both serve on that, public health is involved, and I think we want to bring in public health more closely and see how we can, because there is funding obviously with that, and we are doing some of that work. We've had the same conversations around healthy kids and the parts that we know we do want to, be able to use in our community. So I think we're on the track to getting that, it sounds like. I couldn't remember if we had the question, but I'm glad that you did, so thank you.
I for
it
sure
sounds
remember there being a vape, so I'm sort of assuming there was a nicotine one.
Yeah.
It's like vaguely
And if there's
there.
not, once we get the data back on that, then I think we can look, and maybe you've already seen that, Dan.
And I was just going to add that our data analytics team has joined the data work
Great.
group, and they are just getting started for the council. So we will have an active engagement in that process.
Great, thank you so much. It's coming together over there. It's been building the
Yes.
plane while we were flying it, but we're getting there.
Okay, any more questions? Alrighty.
Okay.
Well, thank you.
Thank
and thank
you.
you to everyone who presented today and who were called upon to present from the crowd and to the board for all your great questions and discussion. So now I will entertain a motion to approve the contracts and their funding amounts as presented today.
So moved, Deborah Chan.
Is there a second?
I'll second.
All those in favor of approving these contracts as presented and their funding amounts, say aye.
Aye.
All opposed? Motion passes unanimously. Okay, so now we are moving on to our executive session to discuss the continued discussion of Public Health South. So Kenny, I'll hand it over to you to read us in.
Mr. President, if I could just make a record and read into the record the executive session item. Executive session pursuant to CRS sections 246402-4A for the purpose of discussing the potential sale of public health property at 6436 South US Highway 8587, Fountain, Colorado 80817. And Mr. President, this does require a motion vote and a supermajority.
Great. Is there a motion to move into executive session for the purposes outlined?
I move.
Second.
Is it a roll call vote, or can we do acclamation?
You can do acclamation.
All those in favor, say aye.
Aye.
All opposed? Okay, unanimously passes. We will get the room and the recording switched over. And let's take a 5-minute break. Thanks.